Welcome back to NephroTube Online Nephrology Lectures. This lecture is about hyperkalemia. We discussed before hypokalemia, hypernatremia, and hyponatremia. All our lectures, PowerPoint is available at nephrotube.com. The recordings of the lectures in both Arabic and English languages are available at our YouTube channel NephroTube, and we have multiple activities on our Facebook group and page, and also we are available on Twitter. Regarding hyperkalemia, the talk is much easier than that of hypokalemia and sodium disturbances. I will cover causes of hyperkalemia, clinical presentation, and treatment. Starting by the causes of hyperkalemia. Before going through the different causes of hyperkalemia, let us rapidly revise the normal compensation and correction of the body to the increased potassium intake. If there is increased potassium intake, by the body, which may elevate serum potassium level, the body compensates this by redistribution of the plasma potassium and entry of the potassium into the cells, which will decrease the serum potassium level, and also by increasing the excretion of the kidney, the renal excretion of potassium, which will correct the hyperkalemia. So any cause which will cause hyperkalemia, which will lead to hyperkalemia, usually may be due to, or theoretically may be due to hyperkalemia due to increased potassium intake, damage of the cell, and outflow of the intracellular contents and potassium to the plasma, or if there is defect in renal excretion to potassium. So the three main mechanisms, or the three main headlines of the mechanisms causing hyperkalemia: increased intake, movement of potassium out of the cells, or impaired renal excretion. Usually, increased intake will not cause hyperkalemia except if the patient has another precipitating factor that may cause hyperkalemia, as movement of the potassium out of the cell or impaired renal excretion. Because if the patient has no, or if the person, not the patient, if the person has normal renal function, so increased potassium intake will never cause hyperkalemia. Let's go through movement out of the cells. What are the causes or etiologies that may cause movement of the potassium of the cell or causing hyperkalemia? Multiple causes with different pathogenesis. Let's start by cell death. Any cell death will cause damage of the membrane of the cell with outflux of the intracellular contents and potassium to the plasma, causing hyperkalemia. And this is very common with trauma to the cells, for example, as in rhabdomyolysis, and also non-traumatic rhabdomyolysis may cause destruction of the wall of the cells. Destruction of the wall of the cells may occur in case of hypothermia, and sure, with tumor lysis syndrome. And we discussed before both tumor lysis syndrome and rhabdomyolysis previously in the acute kidney injury lectures, and they are all available on our YouTube channel. In short, we said before that in tumor lysis syndrome, a patient with tumor who received a therapy for the tumor, which causes destruction of the cells and increasing the potassium in the blood. Even it may occur spontaneously. The tumor lysis may occur spontaneously in large burden tumors. In case of rhabdomyolysis, whatever traumatic or not, there is destruction in the wall of the cells of the myocytes with outflux of intracellular content to the plasma as potassium, causing hyperkalemia. Second cause that may cause hyperkalemia or lead to hyperkalemia due to outflux of potassium from the cell, hypertonic plasma and lack of edema. What is the mechanism or the correlation between both? If this is the intracellular compartment, this is the interstitium compartment and the plasma. If there is here hypertonic solution, it will osmose water from the intracellular compartment to the extracellular part. Also, if there is lack of insulin, there will be a hyperglycemia, which will increase the tonicity of the extracellular part and will osmose water from the intracellular compartment. So in both cases, there will be osmosis and flow of water from the intracellular compartment to the extracellular compartment. The movement of water by a mechanism called solvent drag will drag potassium with it to the out of the cell. So movement of water by osmosis, secondary to increase osmolality of the extracellular compartment, will drag with it potassium to the outside. Also, in cases of insulin deficiency, beside its effect on hyperkalemia by osmosis of water, insulin deficiency will decrease the activity of sodium-potassium pump. Sodium-potassium pump is a pump at the cellular membrane. Its main function is to enhance the entry of potassium from the extracellular space to the intracellular space. Insulin increases the activity of this pump, and in insulin deficiency, this pump activity will decrease. So if the patient has insulin deficiency, this pump activity will decrease, and the re-entry of potassium into the cell will decrease, causing hyperkalemia. Regarding medications, beta blocker and digoxin, both of them cause hyperkalemia by decreasing the activity of the sodium-potassium pump also. For the sodium-potassium pump to be active, the beta-2 receptor must be stimulated. So beta blockers will stop the activity of beta-2 receptors and sodium-potassium pump. Also, digoxin block this pump and prevent the entry of potassium into the cells, causing hyperkalemia. That's why in the management of hyperkalemia, we'll try to use beta agonist to activate this receptor, which will activate the sodium-potassium pump. And also the insulin, as I said in the previous two slides, insulin activate this pump, which will cause entry of potassium into the cell. That's why we will use insulin in the treatment and management of hyperkalemia. Regarding acidemia, whatever the cause, or severe acidemia secondary to severe exercise, one of the compensatory mechanisms of the body in cases of acidosis, that to decrease the acid level in the blood, there is an exchange between hydrogen and the potassium. Hydrogen moves from the extracellular space and the plasma into the cell in exchange with potassium, and potassium goes out to the extracellular space and the plasma, causing a hyperkalemia. So acidosis will cause hyperkalemia. So correction of acidosis, as we will say later, will prevent this pathway and prevent more outflux of potassium out of the cell and prevent hyperkalemia. It is important to exclude pseudo-hyperkalemia because in some cases, if the blood drawing was technically was wrong, there may be cellular hemolysis. If the blood that was drawn by the syringe pushed very fast into the test tube, or pushed not on the wall of the test tube, pushed in the center of the tube, this may lead to hemolysis of the red blood cells and causing factitious hyperkalemia. And also, pseudo-hyperkalemia may occur if the white blood cell count is very high or platelets are very high. So, by the way, if there is a possibility of pseudo-hyperkalemia, but the patient has an ECG changes or high risk factor for hyperkalemia or predisposing factor for hyperkalemia, we have to treat hyperkalemia till we repeat the test. Don't stop the management of hyperkalemia if there is high clinical suspicion of hyperkalemia till exclusion of pseudo-hyperkalemia. But if the patient is totally stable, no predisposing factors of hyperkalemia, no clinical manifestations of hyperkalemia, you may wait till repeating the lab and exclusion of pseudo-hyperkalemia. So we discussed now regarding the causes, the very rare cause of hyperkalemia, which is increased intake, the movement of the potassium out of the cell. Let's discuss what are the causes of impaired renal excretion and hyperkalemia. Three causes. First is renal failure in patients with renal failure. there will be hyperkalemia due to decreased excretion of the potassium. If there is effective volume depletion, if the blood volume that reaches to the kidney is low, whatever, because of total hypovolemia due to blood volume loss, or even if the patient is congested in the venous side but depleted in the arterial side, as in cases of heart failure, liver cirrhosis, nephrotic syndrome. Whenever there is decreased blood flow to the kidney, this may precipitate hyperkalemia by a mechanism that we will discuss now. And finally, hypoaldosteronism may cause hyperkalemia. We said before in the may cause hyperkalemia. We said before in the lecture of hypokalemia that hyperaldosteronism will cause hypokalemia, but here in hypoaldosteronism we will have hyperkalemia, as we will discuss. Regarding effective water depletion, when there is decreased blood flow to the kidney, there will be increased sympathetic nervous system activity. As we know, this is a stressful condition for the body, and the body will redistribute blood from less vital organs to the more vital organs. One of the less vital organs is the kidney. In cases of stress and decreased perfusion, the body decreased the blood going to the kidney, as here the sympathetic causes vasoconstriction of the afferent arteriole to redistribute the blood to the most vital organs, as the brain, the muscles, etc. So if there is effective volume depletion, there will be decreased blood flow and glomerular filtration, which will cause hyperkalemia. Also, decreased filtration, and in cases also of effective volume depletion, the angiotensin system will be acting, causing salt and water reabsorption. This will decrease the blood flow in the the urine flow in the tubules. And if you go back to the basics of physiology, the excretion, or the secretion mainly, to be more accurate, the secretion of potassium into the tubules is dependent on the water flow in the tubules. So with low flow of the urine in the tubules, the potassium secretion followed by excretion will be low, even if the aldosterone is high. So that's why in cases of effective volume depletion, there will be hyperkalemia. In cases of hypoaldosteronism, we know well that aldosterone hormone is very important for the excretion of both, or secretion first, then excretion of both potassium and hydrogen. So in cases of decreased aldosterone level, there will be decreased potassium secretion and excretion, causing hyperkalemia. As usual, all electrolyte disturbances can be occurred by drugs. There are many drugs. There is a very large list of drugs that may cause hyperkalemia, and by the way, most of them are very common to be used by nephrologists. For example, the ACE inhibitors and the ARBs, potassium-sparing diuretics, nonsteroidals, heparin and low molecular weight heparin, cyclosporin, high-dose trimethoprim, digoxin and beta blocker, and we discussed at the start of the lecture how digoxin and beta blocker may cause hyperkalemia. This is a collection of the common causes of hyperkalemia. If you look at them, we'll find them, the causes are classified into either drugs or diseases that will be presented by multiple lab changes and clinical manifestations that will guide you to the diagnosis. Maybe the only one of them that may be hidden is the hypoaldosteronism, but all other causes will be clear enough to be diagnosed without difficult approach to diagnose the cause of hyperkalemia. By the way, I will discuss this equation, which is called transtubular potassium gradient. It is mentioned in many textbooks and literature evidence, but actually in practice, I think that its use is not common. But I will discuss it because it is available in the textbooks, and I will mention its values. Transtubular potassium gradient is equation done by using the urinary potassium, serum potassium, urinary osmolality, and serum osmolality. And in some other references, they use the serum and urine potassium and serum and urine creatinine. Whatever the equation, the main idea for the transtubular potassium gradient is to diagnose whether the hyperkalemia is due to aldosterone action defect or not. Normally, the transtubular gradient is, after you make the equation, is between 6 and 12. But in cases of hyperkalemia, if the tubular transport gradient of potassium is more than 10, that means that the aldosterone action is good, and there is a good excretion of potassium through the kidneys. But if the transtubular gradient is low, this means that the potassium excretion through the kidney is low due to aldosterone deficiency or resistance. And if the transtubular gradient is low, below 5 to 7, let's say average 6, we have to differentiate, is it due to aldosterone deficiency or resistance? In this case, they give the patient fludrocortisone. If the tubular transport gradient is below 6, they give fludrocortisone. If the transtubular gradient improved, so the main cause was aldosterone deficiency, and if it is not improved, so the main cause is aldosterone resistance. But again, if you look to all of these causes, you will find that they will be presented by a combination of manifestations and clinical lab parameters that will guide you to diagnose the case. But maybe the very rare cases, we are adult nephrologists, will not see these cases, pseudohypoaldosteronism type 1, type 2, which is also called Gordon syndrome, which is opposite to Gitelman syndrome. Very rare cases, and will be seen by will not be seen by adult nephrologists, but maybe you may need to the transtubular gradient to diagnose. But overall, most of the cases can be diagnosed without using a transtubular gradient. Also, it is important to know that the dependence of potassium in urine is not standardized or validated. Usually the hyperkalemia is of combined etiology. You will find multiple factors causing hyperkalemia in one person, so it is difficult to depend on the transtubular gradient in general, and it shouldn't affect the clinical decision making. So what about clinical presentation? Clinical presentation differs if the hyperkalemia due to acute increase in potassium or due to chronic increase. Usually, chronic changes in the body are well tolerated by the patients. So chronic hyperkalemia in CKD patients may be tolerated. However, an acute hyperkalemia much less likely to be tolerated and may present with very dangerous manifestations. The first manifestation of hyperkalemia is muscle weakness. And yes, sure, there will be ECG changes as hyperkalemia will affect the repolarization phase. It will cause low amplitude P wave, prolonged PR, wide QRS, and the most famous is peak T wave. But the most important point that we have to know that ECG changes don't correlate well with the degree of hyperkalemia. We have a patient with high potassium level with no ECG changes, and the opposite also is true. What about treatment? Treatment differs if the patient, according to is the patient acute hyperkalemic or chronic. Let's start by acute hyperkalemia. The main ideas of management of hyperkalemia depends on the compensation of the normal physiological response of the body. We will try to decrease the sodium intake by the body. We will try to cause re-entry of potassium in the cells, and we will try to make the body to lose more potassium through the GIT or through the kidney. This is the pathway for the management of acute hyperkalemia. We will go through the pathway, then we will discuss each drug of this pathway alone. If you have a patient with hyperkalemia with ECG changes, if there is ECG changes, you have to start immediately intravenous calcium, and we will discuss now the importance of intravenous calcium. If no ECG changes, does the patient have potassium more than 6.5? If yes, start intravenous calcium even in absence of ECG changes. If not, you will go to the second line. So You have to start intravenous calcium in two situations: if the patient has ECG changes, or whatever the level of the potassium, or if the patient has a potassium more than 6.5, whatever the shape of the ECG. The second line of management is intravenous saline and glucose, plus or minus salbutamol, beta agonist. We may consider bicarbonate if there is acidosis but without volume overload. Consider intravenous furosemide if the patient is not end-stage renal disease or if there is no volume depletion. Consider potassium binder, and finally, if no response, you may consider dialysis. Let's start to talk about each step of this. What is the importance of calcium? The calcium is cardioprotective. Calcium doesn't decrease potassium level. The main function of the calcium to antagonize the effect of potassium on the heart, to balance the depolarization, repolarization phases of the heart. How to give calcium? You can give calcium gluconate or calcium chloride. You give the ampoule over 2 to 5 minutes, slow infusion, and repeat the ECG. And it's better to put the patient on a monitor. If there is no improvement of the ECG after 5 minutes, you have to repeat the dose of calcium gluconate up to 4 ampoules. Usually the action of the calcium appears within minutes, but its effect lasts for than less 1 hour. That's why some literature or evidence or references mention that you have to repeat calcium every hour till hyperkalemia is corrected. Intravenous insulin and glucose, plus minus salbutamol. Intravenous insulin and the beta-2 agonist both will act by causing re-entry of potassium into the cell, and both will cause this by activation of the sodium-potassium pump. Insulin and the beta-2 agonist, as we mentioned at the beginning of the lecture, that beta blocker block the sodium-potassium pump, but beta agonist will activate the sodium-potassium pump. Starting by insulin, how to give insulin? We can give act-rapid insulin, about 10 international units, in 50 ml of 50% glucose to avoid hypoglycemia over 10 minutes. It's important to know that its action lasts for about 2 to 4 hours, so you can repeat the dose after 4 hours. Regarding beta agonists, theoretically, they will cause decreasing of the potassium level, but clinically and most of the available evidences prefer not to use beta agonists. Secondary to two causes. The first, that beta agonists will act by the same mechanism of insulin, so it is enough to give insulin to activate the sodium-potassium pump. The second, that beta-2 agonists may cause arrhythmias and may precipitate angina, especially the patient is hyperkalemic and may have cardiac instability, so it is better to avoid inhalational beta agonists. Regarding bicarbonate and acidosis, as we said at the beginning of the lecture, that acidosis may precipitate hyperkalemia by the exchange of potassium and the hydrogen between the plasma and the cell. So correction of metabolic acidosis by giving sodium bicarbonate will cause correction of hyperkalemia. A general caution for the use of bicarbonate, not only for the management of hyperkalemia, but whenever you use bicarbonate, avoid to give the bicarbonate from the same cannula or line that you give or infuse it from it calcium, as calcium may precipitate with bicarbonate. Also take care, because giving bicarbonate may cause alkalosis, and if the patient is hypocalcemic, alkalosis will precipitate more hypocalcemia with tetany and seizures. Regarding potassium binder can be used in both acute management of hyperkalemia and chronic management of hyperkalemia. First of all, what is the mechanism of potassium binders or exchange resins? This is a powder that the patient can take orally or rectally through enema. In the image in front of you, this resin is formed of sodium polystyrene sulfonate. This sodium in this powder will exchange with the potassium in the mucosa or in the wall of the GIT, and the potassium will be in the intestine, then it will go out through the stool. So this is a cation exchange resin to exchange the cation in the powder with the cation in the wool. The cation in the wool is the potassium that will be eliminated through the stool. There are 4 types of this resin. The oldest two are the calcium sulfonate and sodium sulfonate resins. They can be given orally or as an enema, but the enema preferred to be retained enema for at least 2 hours or better 4 hours. So that this is not practical, I think, except in unconscious patients in the ICU. Take care because this exchange resins may cause constipation, which will antagonize its effect because constipation will decrease the transit time through the intestine, causing reabsorption back of the potassium. So it's better to give laxatives with these resins to improve its action. And the first and the most important point that the action of these drugs appear within 1 day to 2 days. So it is used in the emergency management of hyperkalemia to prevent rebound of hyperkalemia later, but not for the rapid decrease in the serum potassium. And finally, one of the most known complications of this drug is chronic ulceration. It was recognized before was with the sodium sulfonate powder, especially when given with sorbitol as a hyperosmotic laxative. Other resins, rather than the calcium polystyrene sulfonate and sodium polystyrene sulfonate, there is a sodium zirconium and the batyromyl, and both have the same mechanism of action as the first ones that we discussed. Finally, dialysis. Dialysis may be the last line or maybe the first line if the patient is known to be, for example, in stage renal disease. We will start by dialysis. But the most important point in dialysis that you have to put in mind, rebound hyperkalemia. Whatever you use the dialysis or whatever you used other measures, because let's say that you used the insulin and salbutamol or whatever, that will cause potassium to enter into the cell. There is a possibility after some hours that the potassium will go out again into the plasma. So rebound hyperkalemia is common after dialysis or whatever the measures you used. So the patient must be admitted, even if the patient was end-stage renal disease, must be admitted, and the potassium level must be checked up again to be sure if there is rebound hyperkalemia or not to treat. Also, it depends on the etiology. If the etiology of the hyperkalemia was cell death, as in cases of tumor lysis and rhabdomyolysis, the possibility of rebound hyperkalemia is very high if there is persistent destruction of the cells. So monitoring the potassium is very important. And sure, we will try to decrease the potassium intake of the patient, whatever through the diet or through the fluids, and avoid drugs that may cause hyperkalemia. One important point, especially for our end-stage renal disease patient, is the blood transfusion. Blood transfusion is one of the factors that may cause hyperkalemia, as the stored blood contain high level of potassium, may be due to decreased lifespan or the end of lifespan of some RBCs, which will be distracted, causing hyperkalemia of the transfused blood. So it is important for patients with high risk of hyperkalemia, as end-stage renal disease, to give the blood or to transfuse the blood during the hemodialysis session to avoid rapid increase of the potassium level in these patients. What about chronic hyperkalemia? Actually, the available evidence and studies for the management of chronic hyperkalemia, especially in CKD patients, is not large. But the theoretical logical management is available. What you have to do for a patient with chronic hyperkalemia, as in CKD patients, some CKD patients, you have to decrease the potassium in the diet. You have to increase the potassium loss, whatever through diuretics or through the resins. You can use exchange resins. You have to avoid drugs that may increase the potassium level. And you have controlled the acidosis in these patients, maybe by oral sodium bicarbonate. And actually, our patients who are CKD, most of them are on oral sodium bicarbonate for the target of the correction of acidosis to delay the progression of CKD. I hope that the lecture was clear. Thank you, and to see you in next lecture.